Welcome to the Cold Steel Surgical Podcast with your hosts Amir Farouk and Chad Ball.
Dr. Foster, thank you so much for joining us on the Cold Steel Podcast. It's an absolute pleasure and an honor to have you on the show. I've heard so much from Andrew Giles about you and your life and the amazing stories that you've had in your life. But maybe we could start back at the beginning. Can you tell us a little bit about where you grew up?
I'm what they call a third culture kid. My mom and dad went to what was then Northern Rhodesia, now Zambia, in 1950 when I was all of an 8-month-old. So my first memories are Zambia, Mukingi Mission Hospital, where my dad in 1953 opened a rural hospital. And my first memories and first responses to questions going back to what you ask kids what you're going to do when you grow up, I couldn't think of anything better than what my dad was doing. It seemed like a lot of fun. And so I must confess, my first and only memories of anything else you ever considered? No. So growing up in Zambia, I was there until I did my Form 4s, what they called O-levels, with Cambridge Certificate of Education. Came to Canada in 65 for a grade 13 year. I'd been in a boys' school where you didn't see girls more than once a week. And the grade 13 class had girls with miniskirts halfway up there, whatever. And I was blown away by the fashion parade that was grade 13, and squeaked into the bottom of University of Toronto General Science course designed for the high school teachers of the future, only to discover that a third of the class were all thinking about going to medical school or dental school. And McMaster University in 69 was opening its doors for its first intake of students. And they were looking for weirdos and people who didn't qualify with the normal sort of background. And I guess the fact that I had spent 3/4 of my life outside of Canada helped me become I was the youngest member of the class at age 19, squeaking in to the university at Mac, told that I had taken too much science and I needed to do some sociology. So I did a summer course in sociology the summer of 69 and started medical school there in Hamilton in just late August of 69. And then they were playing around with this notion that you could do international electives. And I wanted to figure out as a young adult and medical student what my dad had really been doing, because what you see as a kid and as a teenager when you're growing up, I figured I better see it. And what I discovered was that a third to a half of what my dad did had some kind of surgery tied to it. And I began to realize he was the only guy doing hysterectomies within 150 miles. He was the only guy doing D's and C's. He was the only guy doing cesarean sections. He was the only guy handling typhoid perforations. And the first lady on the ward had a lion bite that had opened her scapula. And I got to hunt the lion a few days later. So I fell in love with rural and surgery and generalism tied all together. I couldn't see that you could do one without the other. I've never subscribed to the notion that if you're going to work rurally, you have to be able to answer the call of the girl who's been snapped by a crocodile, the guy that's fallen off his fancy Chinese motorbike going 80 kilometers an hour down the bush road, the kid who's fallen out of the mango tree trying to pick the mango at the top, who's got a forearm fracture. Just the normal stuff of 78-year-olds who come in who can't pee and have urinary retention. Can you do a suprapubic cystostomy if you can't get the catheter in? All that kind of stuff. And you can't send the patient 200 miles for that kind of care. And so I've been a convinced generalist since 71. I just wrote a letter to the people in Toronto and said I wanted to do the galley course in 72. And would they take a guy who wanted to be a generalist, general surgeon? So I said, how little of general surgery can I do to confine me to the abdomen? And how much of everything else can I do to still be able to be qualified as a general surgeon? So they arranged me to do 3 years of non-general surgery and 2 years of general surgery. So I did a neurosurgery and 18 months of orthopedics and urology and gynecology and plastics and all the other specialties as much as I could to get still a certificate in general surgery in Toronto. And that between 73 and 77. And that was the most fun because my mentors, once they found out that I was a generalist at heart, they'd throw out all the technology and they would push the C-arm out of the room and said, Steve, we're going to show you how we did it in the 50s before all these fancy tools came along. And so one of the old orthopods who was in Toronto General, when he heard that I wanted to do hips, I'm going to show you the old way of doing it. For sure, you're going to find a Smith-Peterson nail sitting on a shelf someplace, and you can nail a femoral neck fracture with a Smith-Peterson nail and a K-wire. And I wasn't in Angola 3 weeks in 78 when the senior leader of our missionary group tripped and fell as she was coming out of chapel on Sunday night, cracked her femoral neck, fortunately not displaced, but wanted to get back to Switzerland without having to be sort of sent in a stretcher. And guess what? I went through the surgical cupboard, found a 3-inch Smith-Peterson nail, found a K-wire, and found a manual drill. And I put the K-wire in, took one flat plate, and recognized my K-wire was in the right place, tapped my Smith-Peterson nail over it, and sent her off to Switzerland. And the AO fancy professor in Geneva couldn't believe his eyes when he saw a lady coming into his office with a Smith-Peterson nail from the 1940s in this lady's fracture. So that sort of established my reputation as a fix what you had to do what you had to do, have the fun of making do.
Can I ask Dr. Foster, when you went back as a medical student to
Yeah.
see your father, obviously it sounds like your father had a big impact on your life and
Yeah.
you were inspired by his mission. I'll make a generalization that you'll either kind of dislike or deviate from what your parents did, or you'll really embrace and kind of want to do what your parents did. My dad's a surgeon. Certainly I can relate to a lot of what you're talking about. What was it like when you went back as a medical student and saw what your father did compared to when you were a child growing up? Like, did you come back and think, oh my goodness, this is a real challenge that my father, like, this is a difficult situation that my father was put in? Or were you kind of, it sounds like you were more inspired than anything else, but can you tell us a little bit about what that was like as a young medical student?
I think the biggest impression I had was, wow, the breadth of stuff he had to know something about. That's what blew my mind. Being able to handle those people with cerebral malaria and the typhoid fevers and the measles complications and the empyemas and all of the stuff, the sort of sheer breadth of practice. And the fact that he seamlessly tied it with surgery just intrigued me, that you could do that at the same time as, and it just seemed to make perfect sense that you didn't have to compartmentalize your thinking about, and when you were the only guy around and there wasn't a doctor within 150 miles, that you really did have to broach, at least find a minimum solution for your problem. that inspired me. I just really, it helped me choose surgery as the sort of starting point, recognizing that I would need to do tropical medicine as well. And so at TGH, fortunately, they had at the end of my fellowship year, we didn't write exams until November of the year, and you finished in July. So when I finished at St. Mike's, I had these 6 months to wait for the exams. And TGH had a tropical medicine institute where they took me as their first fellow. And I had 6 months with them, giving a little bit of at least reading about tropical medicine and seeing patients who had good old-fashioned malarias and stuff that they'd picked up when they were traveling internationally, and gave me at least some reference points to what some of the medical side of what I was going to face. But no, I think I just couldn't believe the width of the challenge my dad faced every day, every single day.
So, I mean, it's kind of amazing that the program was willing to basically build you a training program that allowed you to, get the skills that you needed to then go back and practice in Angola. Can you tell us a little bit about what Angola was like and is like? I suspect many of our listeners will have a vague idea, but can you describe to us what did your practice pattern look like? What is it? Where is Angola? What was the sort of situation in the hospital that you worked at? What kinds
Yeah.
of things would you see?
Well, the Angola's in the southwest corner of Africa. Very few people, when you look at a Mercator projection, get a sense of the size of African countries. Angola is basically the size of the province of Ontario geographically. And with 1.2 plus million square kilometers, you've got what we now know to be about 35, 37 million people living there. When I first went there, the notion of population had been 4 to 5 million, but that was way underestimated by the Portuguese because on purpose they didn't want the rest of the world to recognize that they'd shipped a third of the world's slaves off the coasts of Angola. They had found Angola back in the 1400s, and by the 15 and 1600s were some of the most successful slavers off the west coast of Africa. And the Portuguese, hiding their light and sort of operating in this Portuguese-speaking world, had basically left these 90 tribal groups with 90 different languages, had largely stuck on the coast from in Luanda, Lobito Bay, and Namib, and really only penetrated the highlands of central Angola about 100 years ago. And when missionary groups, Protestant missionary groups, started to go to Angola in the 1880s, life hadn't changed since the mid 1700s. And even today, here we are, 2025, even today, 65% of rural Angolans would live in situations where much has not changed since the 17 and 1800s. In terms of mortality of children, the fudge that gets put out for WHO consumption is based on 2 municipalities that are 50 kilometers from a 4-star hotel in Luanda. So where the numbers are fudged, where lies get told about what's happening in the country, and where malaria today is still 1/3 of all death certificates in the country have malaria written in the diagnosis. And where today a cholera epidemic with over 14,000 victims and a 4 or 5% mortality is running as we speak, and getting very little attention from the present authorities, simply because they've never focused on clean water as a program. And where our leadership in Angola have largely subscribed to how much can they benefit personally out of any U.S. aid or any formal NGO investments in the country passed through the Ministry of Health, with 20 to 25% take on the part of ministers and national leaders. And consequently, ordinary people largely forgotten. And so I face every single day, even in this year, we'll face perforated typhoid fevers. We see people whose fractures from their adventures on 3 wheels or 2 wheels, because the tricycle and the bicycle have become the latest modes of fast transportation. And the number of young people, if you survive age 1, the commonest cause of death between the ages of 2 and 40 in Angola are a motorcycle accident. So we do 50% of what we do is orthopedics now, simply because we're fixing the stuff that the government hospitals tried to fix using inappropriate nails and inappropriate technology. So we've become a sign program. The SIGN program from Seattle has been providing us nails for intramedullary fixation. That's transformed what our ability to care for people has been. So yeah, a crazy world where cancer of cervix becomes a killer because nobody's doing any diagnostics or any registration of ladies. Very few get a pap smear. And so cancer of cervix and breast are all over the place. Cancer of the bladder from schistosoma, all over. We would see bladder cancer every week. Yeah, the whole gamut of ordinary stuff. Peptic ulcer disease, big time. Omeprazole is hardly heard of. And I'm still doing bigotomies and gastroenterostomies. Good old-fashioned stuff.
So, Dr. Foster, when you went back to Angola after finishing your training, can you give us a little snapshot of what kind of operations were you doing? What kind of things were you taking care of? What was the volume like when you went back and started practicing in Angola?
Yeah. Well, I made a list of the first 1,000 cases in the first 8 months I was there. There were 117 different pathologies. I wasn't doing the same thing more than twice or 3 times. I was just blown away. You know, 1 minute you're fixing an incarcerated hernia on a guy who's had a hernia for 10 years and then finally incarcerated. And then the next guy needs a prostatectomy and his prostate's so big it looks like a grapefruit. So you're pulling it out transvesically because no one's ever heard of a TUR. And then you had ectopic pregnancies just happening left, right, and center, and cesarean sections night and day. And then all the plastics for people with burns who had fallen in the fire with their uncared for epilepsy and had burned and contractures of elbows, knees, and you were reconstructing these people. And then gunshot wounds, because in the early 70s there was a civil war in Angola as they were trying to get rid of the Portuguese from 61 through 75. And then independence comes in 75, and there's 3 warring groups. They all start taking the bullets to each other. And so from 75 through 2002, a full-scale war was going on between parties. And we were stuck in a peripheral hospital, 200K from any town, where we were labeled as the only place to go. And so I worked at a place called Kelekembe, which was 200K from Wambo and 200K from Lubango, and smack in the middle of the war zone. And the soldiers needed help from both sides. So we said we would treat patients who didn't bring guns. If they had a gun, they left them at the front door of the hospital. And we would say we don't care what party you belong to. As far as we can tell, you're an Angolan. And if you need help, we'll give it to you. And that became our cachet, because both sides would accuse us of caring for the other. And when Red Cross came and visited us in 84, 85, by coming by plane, they'd drop in and say, well, we hear Savimbi complaining that you're caring for the MPLA. And then when in Luanda, the MPLA is complaining you're treating Savimbi's boys. And I said, exactly. We're treating boys who got shot. I don't care by who. And so, yeah, 1 year we had 46 landmine victims. And in 1 month, in 86, we had 46 landmine victims. I think I treated 178 landmine victims in 1 year that year. Over the 12 years I was there, almost 1,000 landmine victims.
So, Dr. Foster, hearing you talk about this, it really does sound overwhelming from multiple perspectives. I mean, you're talking about the breadth of what you had to do, what your father had to do, what you continue to do, and then, being in the middle of a civil war. It would seem just difficult to carry on. And you've not been there for a year, 2 years, 6 months. You've been there for
47.
yeah. So how was it that you were able to keep going in these situations? Because I think, anyone with a shred of humanity seeing 46 landmine victims in a month, or all the things like you talked about, the consequences of untreated disease, it'd feel overwhelming after a period of time. So how did you carry on?
Several things happened, and in some sense, in the goodness of God and these things, several things happened. One was recognizing I couldn't do it all by myself. That was probably the biggest insight, was that I had nurses who could open and close the laparotomy as fast as I could. So I said to them, we're going to do a vagotomy on this next patient. You open the midline incision between syphiloid and umbilicus. Get the patient ready. I'll come and do the vagotomy, and I'll run the gastroenterostomy. And then you close, and I'll go on to the cesarean, and I'll go on to this. And so I had a nurse who had done 22,000 spinals. I did my vagotomies and gastroenterostomies under spinal. We just used high spinal. And you had to get the operation done in 40 minutes. So you learn to work fast. And if you had any problems, you give them a little bit of ketamine at the end. And I kind of found out that if I had 17 cases booked between 8 o'clock and 1 o'clock in the afternoon, I could get all of those cases done because my nurses did 2/3 of the work. I taught them how to do a hernia. What am I going to do the hernia for? You can do it. And you do a Bassini. You don't do a fancy operation. But a Bassini works 90% of the time. And if they failed the Bassini, then I do a Scholdice. And so I only did failures of primary hernia repairs myself. And in that way, I figured I get 90% of the traffic dealt with by my nursing staff. I could do the anesthesia with my nursing staff. And it just became, if I had to be called in the middle of the night, I had nurses who had learned to do cesarean section so they could share call with me. And I didn't need to get out of bed every night to do the Caesars either. And having nurses learn to do that, and they only had grade 6 education, taught me you didn't have to have 7 years diploma and postgraduate degrees on the wall to do cesarean sections. And that's been shown in Malawi. Thousands of cesarean sections are being done by medical techs as reliably as those with their 7 years of degrees on the wall. And we're playing games with people and denying them health care because we're waiting for people with diplomas. And I think and if there's anything that your podcast can do to help recognize that we're playing games with our diplomas as big boys in the MD pond, we're forgetting the needs of ordinary people. And we're actually denying them their care. And I think as a Christian, that just doesn't wash. I just can't live with that.
Dr. Foster, you bring up a couple of really interesting concepts there that I'm hoping we could explore with you. The first is the idea of efficiency in the operating room. And you're talking
Mhm.
about doing a significant number of cases in a significantly short time. And, when I extrapolate that to some of our, tertiary care institutions across Canada and the US, they could not imagine doing that many cases in that period of time and being that efficient. And when I say they, I want to be specific. I mean everybody from the
Yeah.
surgeon to the nursing staff to the management to just the whole system. So, first question is, I'm curious how you view that superb efficiency in the context of what we might experience in Canada, whether that's in a rural facility or an urban facility. And then the second question is, I was hoping you could explore a little bit more about exactly what you're talking about in terms of training other folks to do components of these procedures or the procedures in total. There's been a very strong resistance to doing that across this country. And I think a lot of us think to the deficit of local patient care for sure. I'm just curious how you bring both of those two concepts back into Canada with your experience.
Humility has not been a feature of too many physicians. Most of us are quite jacked up about our diplomas and all the extra years of education we had and have. And that's not to put the education and the diplomas down, but it's to say how much of it is playing games with our billing features and our personal incomes rather than delivery of health care. And I think, quite frankly, the lesson I see being repeated again and again in sub-Saharan Africa, where if you want physician and healthcare retention, Mozambique learned that they couldn't keep doctors in their rural areas, but they could keep their technicians in rural areas. So their cesarean sections are being done by their techs because they're there. Their doctors didn't stay. They went back to the national capital region to sort of make their incomes and make their fancy homes and make the lifestyle they wanted for their kids quote unquote appropriate. And that's not to ignore the fact that we need to think about our kids' education. That's not to ignore the fact that we need to think about the reasons why docs don't want to go rural. But I increasingly am finding that if we're committed to the needs of people, we ought to be having the medical legal conversations about recovery. I write the orders for my 17 patients operated on, half of them by my nurses. I cover the register legally because I signed the certificate that said this patient's surgery was done and the prescribed surgery was carried out. If and I am fighting this battle right now with Angola, where we are trying to do with the Pan African Academy of Christian Surgeons, create the generalist surgeon who will work rurally, and finding that they're already trying to define general surgeons as only abdominal surgeons, courtesy of the Cubans. And when we tell them that 40% of what a guy needs to do in rural areas is orthopedics, and about 20% is obstetrics and gynae, and another 10 or 15 is urology, and then another 10 or so is plastics, and there's going to be a lot of skin grafting needing to be done. Who's going to do that if we don't train these guys to do these things? And it just seems to me we need the political will and the ability to sit down with our colleges and our professional colleges. This is the thing I'm calling for as folk in Africa, where we're needing to sit down with our colleges in Angola and talk about, are we committed to rural healthcare, or are we going to just continue to bamboozle people and pull the wool over their eyes, waiting until we have a doctor-patient ratio that approximates that of Cuba. It just doesn't make sense. I'm working in a context where rurally we might have one doctor for 50,000. And if we're waiting for one doctor for what Cuba's got, 1 in 100, that's just not going to wash. It may not happen this century or the next. And consequently, we need to solve the conundrums around rurality and around access and around generalism. And it seems to me the only way forward I can see in the short term meaning next 25 years, that we've got to find ways to multiply the capacity of ordinary docs who care enough about rural folk to imagine that their followers, they need healthcare just like everybody else does.
I want to pick up on what Dr. Ball is saying, though, and because I think this is a really key thing that you're talking about, which is really empowering, the non-physicians, the techs, the nurses, to be able to do basic procedures, because these are things that what you're talking about are, these things are going to save people's lives. So what was your training like with your nurses and your techs to be able to get them to a point where you felt comfortable signing off on what they had done as if it had been your own work?
They would scrub with me on the first 50 cases. And we would do 50 cases in the space of, wow, when you're doing 2,000 cases a year, you're doing 200 cases a month. So in a space of a week, you've gone through 50. And so you work with the same guy doing it again and again and again and again. You get the anesthesia, did you see how sick this patient was? Did you see how his hemoglobin was 7 before we started? What did you think about getting a transfusion organized? Ooh, forgot. Well, next time, no, sir. That kind of thing, thinking the step by step from the time of we met the patient and emerged together. What's he going to need? And how are we going to solve it? Am I going to do all the work? No way. You're going to be helping me. What do we need to think about? And I was teaching med physiology to my third-year nursing students and teaching them about percentages and teaching them about blood volume, holding up a gallon bucket in front of them to say, most of us don't have much more than this in our whole circulation, and if you spill half of it on the floor, what's going to happen to you? That kind of stuff, it just had to be as literal and as physical as possible, because most kids didn't have an idea of volume, didn't have an idea of weight, didn't have an idea of what a liter of anything was, let alone 10 cc's. And so working with people who were grade 6, grade 8 educated and whose Portuguese was not much better than mine was, we had to find ways to move forward. And the fun of it was discovering lights going on in people's heads and seeing the joy they had in caring. And I think when you have an ability to transmit care and it can make a difference. And 2 liters of saline got into that patient before we cut him. Wow. And that thing happened. And we remembered to get the transfusion sorted. And just that kind of stuff, and seeing lights going on in your nurse tech's head, realizing that it can happen, and it does. It takes time.
So how do you explain this conundrum really in the modern surgical world where, on the one hand, you're talking about being just this amazing generalist surgeon, being able to handle sort of whatever walks in the door, with this incredible subspecialization that's occurring in developed countries, right? Like, the jokes about people operating on only the right ear, right? Like, and that's happening for good reason, in the sense that we know that there's volume and outcome relationships when folks have volume and they do complex, like Dr. Ball does Whipples, and we know that, for example, Whipples have a very good volume outcome relationship.
Yep.
How do you sort of solve that conundrum? And I think I know what you're going to say, but in terms of like saving people's lives, you know, what else can you do? But I'm curious how you wrap your head around this conundrum in modern surgical training and modern surgical life.
To admit that it's an issue is hugely important. I think at the same time, what I try to do when I have residents and fellows coming my way, people like Andrew when he came years ago, when my orthopods come, the kids who are in R3 ortho year, we're doing a forearm fracture and putting 2 plates on a radius and ulna and da-da-da. Then we turn around and do a cesarean section. And they look at me and blanch. I've never done such a thing. Well, it's time you did. It's surgery. Come on. The belly is not a mysterious place. And the gynecologists who don't know what to do when the small bowel's stuck to the top of the uterus. Come on. It's a pair of scissors and a pair of thumb forceps. You can dissect. Come on. And the people who want to do laparoscopic everything. And I tell them everything's wet hands in my environment. You're going to get your hands into people. And they look at me like, what? Yeah, come and spend a week with me and you will get your hands wet. And so I don't know any other way to knock the silos and perforate the side walls of the silos, if only through direct contact with the real world, where there's 650 million sub-Saharan Africans don't know what modern healthcare means. And at some point, aren't we going to stand in some sense in all our fanciness in the West and in the North, stand accused of ignoring the needs of our fellow man? And to me, if we are committed to the best surgical outcomes and care, and we know that specialization has brought us to a pinnacle in some sense, and yes, that's a wonderful thing to learn in the microcosm that is Canada or the microcosm that is North America. But let's face it, there's only 400 million of us in North America. And what does the rest of the world look like? And it's somehow, we need to break down the comfort levels of those who've chosen to live in the silo and say to them, there is a bigger, uglier, messier, needy world out there, that if you're committed to global surgery and understanding how to bring others along, just manufacturing silos isn't the way to do it. Somehow we have to create a conversation about what care for our fellow man looks like. And yes, and maybe in 40 and 50 and 100 years, some of those silos will start to emerge as the privilege of more and more docs lead to doing a better job of getting that Whipple done. And there's no argument that a guy who does 30, 40, 50 Whipples a year has much better result than the person who does 4 or 5. Having said that, my colleague's done 6 Whipples in the last 3 years and in Lubango with 1 mortality and had 3 years survival on all the other 5. So things can be done. And, a fibular transplant free with just loops with no operating microscope into the jaw. So it can be done by some people who are very careful and assiduous. I don't have that kind of patience. And the 6-0 sutures stuff on facial arteries isn't my cup of tea at all. But there's place for it, and I think we've got to keep this tension a healthy one. But what calls to me is accountability. How am I going to stand and know that so many of the ordinary folk in Angola are denied the basics? And consequently, I'm still focusing on the basics. And so I believe getting people's hands wet is a good thing to do.
Yeah, I think we would all couldn't agree more. One of the things that really you're describing over and over again is repetitions, it's volume, and the impact of that on competency and in general under the umbrella of training. And one of the concerns when you look at modern surgical training is the number of reps that somebody will get in their residency, which has gone down anywhere. It depends what you believe and what you read in Canada and the US, but somewhere around 50% lower.
Wow.
So, like that training arc then obviously extends well into your quote unquote faculty job on this continent and other places as well in the world. And from my point of view, I won't speak for Amir, it's become a real issue. And I do wonder if sort of a return, and I don't mean this in terms of the complexity of the care that you provide, but returning to the basics, back to basics and doing volume and working your way up in terms of complexity. I see huge gaps in that in our current education system. It's concerning, and someone like you doing that work is such an important jewel. I think that not to send the whole world to you to train, but boy, oh boy, would our trainees benefit from the experiences you live day in and day out.
Well, the Andrews of this world who did that for 2 or 3 months are testaments to it. They've gone on to do other things, yeah, but it opened their eyes. And I've had the privilege of working with the young men and women who've come our way from Canadian institutions and some from places in the States who are now leaders. People like Robert Riviello spent a year with me in 2006, and he's leading the faculty there in global surgery in Harvard. And, he points to me as sort of his grandfather in rural surgery. And, I'm just an old guy who had a lot of fun. I think generalism is way underrated because it's so much. I love the diversity and the ability to do a abdominal perineal resection 1 minute and then a PID case the next minute, and then a good old-fashioned peptic ulcer. And, the guy's can't afford his omeprazole. He comes to me and sits me down and says, a year of omeprazole is going to cost me the same as a vagotomy. Why don't I just get the vagotomy done? And it's the patient who's convincing me because he's done his math. So, yeah, it's the
That's incredible. It really is incredible. I don't want to harp on this too much or pick on this too much, and maybe I'm displaying my own insecurities and vulnerabilities in asking about this, but I really do think that many people in your situation would have been overwhelmed.
yes.
I've seen when I was doing my master's in Boston, we had one of my classmates was, someone who had worked with MSF for a number of years.
Yeah.
And she was completely burnt out. And I think with very good reason. Like she had seen some very, very terrible things. And I'm sure you have too. And I know faith is a big part of who you are and what drives you. I'm wondering if you can talk a little bit about how that perhaps is an inspiration to you, or maybe just more generally, what keeps you going in the face of so much human suffering.
Well, certainly being challenged by the faith that was exercised by my Angolan colleagues, guys who had very simple experiences in following Jesus and who had the ability to see that they had the privilege of following in the steps of Christ. And, we've just celebrated Easter, and most of us should remember that Jesus got beat up and killed on a Friday, and then the boys are all surprised by resurrection on Sunday. And this whole issue then of practicing and unpacking a faith that's pretty simple at the basis of it all. Did Jesus do what he did, and does he still live and move and breathe inside the hearts of ordinary folk like us? And that's what I meant. And men and women who had lived that, didn't think it was too much to die for it. I had a 35-year-old colleague who died in the process of working in a rural clinic. And their faith, their living, their light inspired me to think, my goodness, if they were willing to do this, then what's stopping me? So that's certainly been a help. But burnout is a real thing, and many missionaries are confessing to it and recognizing it. We would, for example, in the worst years of the 90s, when urban warfare came to the city we were living in, we took a break every 3 months just to get out for a week or two. And we recognized that we needed to call each other on the stress of, when did you take a break? When did you get to the beach? When did you just get out? Our mission organization allowed us to travel much more commonly than had been the previous pattern of 1 year and 4 years, when you're in for 4 and out for 1. We started going to 1 month or 2 months every other year. And that kind of breaks, more common, helped. And then I realized that if I could train other people to do a lot of my work, my conscience wouldn't bother me about if they could do a reasonable job. And that was a huge help in terms of just being able to say, well, I did not leave my patients completely without help. And even when we had to leave the mission hospital at Kelukembe, the nurses ran it for the following 14 years before a doctor came back. And they did a reasonable job. Their mortality rate, we still go through the numbers. The mortality rate of their 1,000 cesarean sections done during their 14 years was less than the state hospital's mortality rate for cesarean section. And so, yeah, we can argue about all the fanciness, but sometimes keeping it simple and living a sense of the faith walk that we've tried to live has been challenged by men and women around us. Truck drivers who come to me and say, what's the problem? Landmine on the highway? Ambush on the side of the road? Who gave us the truck? Wasn't it God who sent us the truck? Wasn't it God who sent the supplies that are in the container that's sitting in Libido Bay 400K away? Let me go and get it. The driver won't go. I can't pay him enough to go. I'm trying to organize the transport for this container, and the driver says, no way, I'm not doing that. He can't pay me enough to get on the road. I can't. Then another guy steps forward and says, let me go. I'm older. I'm in my 60s. If God calls me into his presence, I'll just get there faster than you. And so he gets in the truck, comes back smiling ear to ear. He says, I've never driven a V8 diesel Cummins before. This thing could pass every truck on the road. And we had an 8-ton Chevy that just happened to have the best diesel engine that Cummins could make in 1980. And he had all the fun of driving a truck you never would have believed. And he was just smiling ear to ear. He said, I left those guys behind. And we used to have to travel by convoy, because the convoy system was developed to try to reduce the attack rate. And he said, no, I wasn't going to stick with those convoy boys. I just accelerated down the road. So it was simple guys like that taught me, my goodness, you can dress up all the theology you want, but these guys' faith was so basic and so simple. It just blew me out of the water to say I had the privilege of working beside guys who thought it was a privilege to work and love and show the care and to do the kinds of things that Mother Teresa reminded us all. She saw the needs of and saw the face of Jesus in the least of these. And that's the privilege I've had, being reminded again and again by Angolans that simple faith doesn't have to get too many theological P's and Q's. It just has to get practiced in invisible form so that it's unpacked in that sense.
Yeah, that's such a beautiful thought and a beautiful way of explaining how that, what that faith looks like in people's hearts. Um, obviously you've been in the global surgery space for many, many years. I'm curious what, besides the sort of empowering of other providers to be able to provide care, what do you sort of see as being the big challenges and big pushes and directions that global surgery needs to take in the next 15 to 20 years?
Well, I would second what Mark Schreime said the other day in the podcast. You interviewed him and asked almost the same question. The fact that funding hasn't been committed to integrating surgery into care, to me, is one of the silliest or the most stupid or perhaps the most egregious mistake that we're making. And somehow tail on the donkey isn't going to cut it. And somehow we do need to have an integrated conversation. The valid nature of the kinds of things Lancet Commission talked about in their studies between 12, 14 and published in 15 just underscores how surgery, and I found that I could use the credibility I had gained as a surgeon in public health in ways that the ordinary kids talking about public health couldn't, because they weren't seen as real doctors. They were just a bunch of people who talk. But the real doctor is the guy who cuts you and opens you and fixes you and puts you back together. That's the real doctor talking. And when the real doctor talked about clean water, they listened. And when the real doctor talked about vaccines, they listened. And it just seemed to me somehow we've just somehow allowed this siloism. And so the public health silo and the district health care. And my minister of health in the province comes to me 2 years ago and says, Stephen, I have 13 municipalities in Wheeler province. I've only got 2 functioning operating rooms in these 13 municipalities in their district hospitals. How can we change this? Because if I put ORs in these hospitals and I don't have doctors who know how to use an OR, I've got a problem. I said, I'll deal with the human resources. You deal with the physical resources. You build them. We'll train them. So in some sense, I think we have to begin a very big conversation. And I think I'm talking about organizations that I belong to, like SIM, some of the big major mission organizations. We have hundreds of Christian docs in our ministries scattered around Africa. But do we sit down and talk with our universities and our WHOs and provoke conversations about the changes we want to see in rural healthcare? No, we get on and we start competing with one another about doing something better than the next guy, but we're not basically driving a conversation that could be population-based, epidemiologically based, accurate in its focus, and then thinking about why do people quit and why do they burn out and why don't we retain them, and asking ourselves those questions. Why aren't we learning from our Australians who are doing rural family doctors with RUR after it and giving them a 40% raise if they're going to go rural, and making sure their kids get access to good education, making sure we got an airstrip in the back of every single district hospital so we can get medevac. I got an organization known as the MAF Canada, Mission Aviation Fellowship. They want to put a second airplane just to run an ambulance service for the hospitals we build and the places we go. Somehow we have to have these larger scope conversations. Bring our universities along. Get our Global Surgical Foundation recognized. our dear Calgarian who's sitting there in Geneva of all places, trying to raise money. And he's one of the people who's got interested in the Germans doing something to fund some stuff in West Africa. Somehow we got to raise the billions or two that we need to get global surgical credibility, if you will, and tie it to good epidemiology so that people can see it's incontrovertible in its impact. And because, we've done a bad job of doing that.
Dr. Foster, you've highlighted a small amount of the really legacy level work that you've done for a long period of time. We're curious, what sort of projects do you have that are coming your way in the near future, and what are your long-term plans?
Long-term plan at this moment is setting up a foundation here in Canada to fund rural healthcare work in Angola. We're putting together, as we speak, a lawyer is registering what we call the CML Foster Foundation. The CEML is the Portuguese acronym for the Evangelical Medical Center of Lubango. But it's basically to fund a rural training program for PACS surgeons so that the general surgeons we turn out are truly generalist, and they will do orthopedics, urology, gynae, and plastics in addition to their general surgery or their general abdominal surgery, and that they will be put in rural places and church-related hospitals, because right now the only model we've got that seems to be working is where there's church relationships and where there's honesty and integrity, because the ugly challenge in Angola is to face them with the reality of or their minister of health who wants 20 to 30% before anything goes, and she's not going to get it from us, and somehow we have to be polite about telling her that, and at the same time reminder we're called to care for people, and as politically incorrect as it is to do that, that's what we're going to set forward to do. And we're starting something in Angola, trying to find private funders that are not state actors, because state money just seems to disappear. So we're going after that. And at this moment, we're only looking for a foundation and with about a 60 million baseline as a sort of start. We could and should and might go further, but we figured, hey, if in the next 4 or 5 years we can get this foundation secure and start training and we've already started training, we will be graduating our first PACS surgeon come 2029. 2 of them will be turned out if we're successful. These kids had to learn Portuguese, they had to learn French, they had to learn English. They're going to write their exams with COSEXA in English. So their English proficiency is huge, because Portuguese doesn't help you speak English. So, we've got a huge task ahead of us. There's 3 or 4 of us involved, just a handful. We need some more people who would love to join us. And so if anyone listening to the podcast gets interested or tweaked about what working in Angola could look like, I'd love to chat. But that's about my next 4 or 5 years.
That's amazing work. And we'll be sure to put your email in the show notes so that people can get a hold of you. Dr. Foster, it's been an absolutely fascinating discussion. We haven't even really had a chance to hear all your amazing stories that Andrew told us a little bit about you doing roadside catheterizations and hunting leopards, and then all sorts of stories. And I think we could probably keep you on the show for hours and hours. But I wanted to end our conversation with you by asking you to give, if you could go back in time and give yourself advice, maybe as when you were first starting out, or maybe as a final year resident, what advice would you have for yourself?
I think I should have recognized the role of epidemiology far sooner. The ability to track and monitor what we were doing in real time, and then be able to build a case not just on surgeon backslapping and meeting people sort of on an individual basis. I should have, could have, might have spent more time detailing and data collecting so that we had incontrovertible argument for the things we needed to be doing, rather than just sort of waiting for the situation to speak for itself. Part of it, there are lots of excuses I could trot out, but I think if I had to do it again, I would make a much more intentional plan to find somebody with epidemiological training to stand beside me and stand with me and do the data, and perhaps start speaking about the ugly realities a bit sooner. I felt myself letting the thing speak for itself, letting my patients speak for me. And when you've operated on about 45,000 people, you got quite a few folk out there blowing trumpets. It's very useful sometimes when they're trying to deport your wife and throw you out of the country, to have people you can call and all of a sudden cash in on, because it turns out that the Minister of Foreign Affairs is a friend who grew up on the mission station where your daddy was back in 71, where you were playing soccer with these kids, and that kind of thing. I should have been much more intentional about collecting data.
That's a really powerful, actually, piece of advice. And not surprising to me in some ways that you would give us something totally unexpected and not what I was expecting you to say. So I think that's just par for the course in speaking with you. I will ask maybe one additional question, which is, if there's someone interested in being involved in quote unquote global surgery, what advice specifically for residents or young surgeons who are interested in getting involved in the field, what advice would you have for them?
Don't give up. You're going to get all sorts of crazy advice. And most of it's, if it's not based on people with real world experience, it ain't going to be worth the paper it's written on. Go and see for yourself. Instead of going and being peripatetic and go back and go back and go back, go to the same place 2 or 3 times. I found the most effective thing has been repeat visitors who come to see us in Angola, because they came with a question, we saw only half an answer to the question, they came back with a sharper question, and that helped us take another step. I had a young man in 2011 say to me, "Why are you reusing all your ex-fix stuff? Why are you reusing all this stuff?" I said, "Because I don't have a source for anything better." Well, he went home, and after a basement presentation in his home in Calgary, where I had been used to $5,000 fundraisers in the basements of churches, this kid puts an 8-minute video together and invites a few friends from his Calgary family, and he raises $50,000 in one night and buys us 2 sets of SIGN signed nails from Seattle. And that started our intramedullary nail program, based on one kid coming back 3 times saying, "Foster, you're not doing what could and should be done." I'd never heard of signed nail, but he had heard about them on the internet, and I had to be introduced. So having young people who have a passion and who sharpen their questions and keep coming back, we've been so blessed. So yeah, don't give up. If you mean something in global surgery, don't give up. Keep doing it.
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you have comments or questions, please email us at podcast.cjs@gmail.com. Thanks for listening.